So we talk about global neurosurgery, right? So I'm now the co-chair of the Global Neurosurgery Committee, and we've kind of wordsmithed the definition so we can all agree on what we're talking about. And we came to this definition. It is the clinical, and we're all familiar with the clinical practice, and the public health practice of neurosurgery. We're really introducing the population, the health system aspect of practice of neurosurgery. And the purpose is to ensure timely, so it's about access, safe, quality surgery, and affordable. It's really about equity, making sure that everybody has access, and to all who need it. And we want everybody to sort of use this definition from now on, because we've had multiple definitions going back and forth, but this is the one that's been agreed upon. This is a picture from the COSEXA exams. This was in Mozambique about 2 years ago. And I put this here because if you look at all the talks, with the exception of Marie's talk, we focused on a lot on education and training. And that's not, it's not a surprise, because this is what we're used to. And this is a perfect example. And we have Mike Hogland, we have representatives from Norway, UK, US as examiners, and then we have some African examiners, right? And actually 2 of the Ethiopian examiners were my former residents, which I'm very happy to report. But education is one component of global neurosurgery. When I worked in Ethiopia, and I also worked in Cambodia, we just assume that the government or the health system will absorb these new trainees somehow. And we just take things as they're given, saying, well, there'll be a facility, maybe they'll have a CAT scan. If they don't, they'll make do with it. Maybe they'll have an ICU, maybe not. And it became clear to me that, can we change that? Do we have to accept status quo as sort of whatever the government's willing to give us, we'll take? And I would challenge you that we have an opportunity to actually engage in policy dialogue with ministries of health, like Bob has talked about, and then try to, so when we produce neurosurgeons, it's more of a push, and hopefully the neurosurgeons will go out and build surgical centers and then expand. But what if we can get the ministries of health to also prioritize surgical care and neurosurgical care, and then match our efforts with the government's efforts? It's a push and pull type of thing. And I will tell you, there has never been a time better than it is now to be engaging with policymakers, and I'll tell you all about it. And for me, it started with this report from the Lancet. I think Bob put this up. There was a Lancet Commission on Global Surgery. John Moore is my boss, Andy Leather, and Lars Hagender. And they looked at the current state of surgical care through the lens of equity, specifically at who's not getting surgical care globally. 5 billion people, 17 million do not have access, 17 million people may be dying every year as a result of inability to access these surgeries. They also came up with a number, 143 million operations currently not being done, and as a result, people are dying and people are getting disabled unnecessarily, and most of this is in the developing countries. And I don't know if some of the industry people are here or not, and I just do a simple arithmetic, 143 million operations that we're trying to get done over the next 10 years per year. This is every year. There's a massive market that will be created. If you just say $1,000 exchanges hands for every operation, potentially we're looking at a $143 billion market that is going to be created over the next 5-10 years, if we're successful. So I work at the Harvard Program in Global Surgery. I do some of the policy and advocacy work. I'm faculty there at Ben Wharf. I think someone mentioned him. Is my partner in this. And then we have a slew of people, that including fellows and researchers.
Hey guys, thanks for watching. To continue, please log in or create an account for free. Thank you for your support.